I will now introduce you to Dr. Tiffany Vino, who will moderate the webinar and assist the panelists with any questions and comments. Dr. Vino is Associate Dean for Faculty at the University of Michigan, UM's School of Information. She's also a full professor at the Schools of Information and Public Health at UM. Her research focuses on community health informatics, or the use of information systems and services to improve the health of marginalized populations and reduce health disparities. Tiffany, the floor is yours.
I will now introduce our two speakers for today. The first is Philippa Clark. Philippa Clark is a professor in the Department of Epidemiology at the University of Michigan's School of Public Health. She is also a research professor at the University of Michigan's Institute for Social Research. Her work examines the social determinants of disability with a particular focus on the built environment for adults aging with disability. Robin Rontal leads the Center for Health Research and Transformation, or CHARTS, data analytics and consulting projects focused on current healthcare issues and trends, collaborating with local, state, and national organizations on data acquisition and methods. She has focused experience in the area of healthy aging. We will now move to our speakers. The first talk that we will hear is called Broadband Internet Access, Implications for the Health of People with Disabilities. Over to you, speakers.
Thank you very much, and good afternoon to everyone. I would like to move to the next slide, which has the agenda. Today, we're going to cover briefly a current state review of broadband internet access in the United States. Then Dr. Philippa Clark will describe new research findings that she has been investigating on broadband access and the implications for the health of adults with disability. Then I will discuss some of the recent policy initiatives and next steps. And then Dr. Vino will facilitate a discussion to respond to your questions, and will provide discussion and answers. Next slide, please. Many of us take for granted our access to fast, mostly reliable broadband internet as we work remotely and participate in webinars such as this one today. When we talk about broadband, we're referring to the high-speed, high bandwidth communications infrastructure that supports internet services. The FCC defines this as a minimum of 25 megabits per second and 3 megabits download or upload speeds. And I'd like to note that these speeds support only about 2 users and up to 5 devices. So most of us are familiar with higher speeds than this. Next slide, please. Currently, approximately 19 million Americans lack broadband access. This represents about 6% of the total population. However, it's noteworthy that in rural areas, nearly a quarter of the population lacks access, and in tribal areas, nearly a third of the population lacks access. In addition, 30 million Americans live in areas without minimally acceptable speeds for their internet access. And more than 100 million have access but don't subscribe, primarily because of the high cost of internet services. Next slide, please. I want to review the recent Infrastructure and Investment Jobs Act that President Biden signed into law in November of last year. This act addresses traditional infrastructure needs such as roads and bridges, but it also provides $65 billion for nationwide broadband infrastructure development. The majority of these funds will go to the states based on a formula that's going to include the percentage of the country's underserved areas and rural locations. States will be deciding how to distribute these funds based on a grant process, and broadband providers will be required to match at least 25% of the funding. The emergency broadband benefit was established in response to the COVID pandemic 2 years ago. And this provides discounts up to $50 for low-income families to afford internet services and function in ways to support education and remote work. This new program will provide a $30 discount for families who are under 200% of the poverty level. The digital equity, inclusion, and literacy programs will provide states with funds to develop comprehensive plans for equal access for underserved communities, and will also fund projects such as Wi-Fi hotspots and digital literacy programs. And then finally, this act requires changes in the communications and labeling of internet products and pricing to help consumer understanding. I'm going to now pass to Dr. Philippa Clark, who's going to discuss her recent research findings on broadband internet and the health of adults aging with disability. Philippa?
Great, thank you, Robin. Hi, everybody. I'm Philippa Clark, and I'm really excited to present to you today some of the work we've been doing looking at the relationship between broadband internet access and the health of adults who are aging with disability. I want to make it clear that this is a kind of a unique population. So due to advances in medical care and other technology, the average age of people living with disability-associated conditions such as cerebral palsy, spinal cord injury, or multiple sclerosis is increasing. So that really we're seeing tremendous progress in individuals living into older ages with disabilities that they have acquired at birth, in childhood, or before midlife. This is known as aging with disability. But distinct from people who are aging into disability, as they say, who have been living lives without disability and are just getting older, people aging with disability can experience what is called premature aging, which is they're more likely to end up with medical conditions such as hypertension, obesity, heart disease, and diabetes. They're also more likely to experience secondary health conditions that are secondary to their primary disability-associated condition, such as bone loss, fractures, rotator cuff injuries, and pain. So this chart is just a quick overview of some of the differences in the kinds of health problems that people aging with disability experience after the age of 40 compared to those without disability. Data comes from the US Panel Study of Income Dynamics, and you can see that people aging with disability, which are the dark blue lines in this chart, dark blue columns, they are more likely to have a diagnosis of heart disease, high blood pressure, diabetes, arthritis than those aging without disability. Similarly, health behaviors of people aging with disability are often not as good as those who are aging without disability. People aging with disability are more likely to be current smokers, to be sedentary, and to be obese. But the reasons why people aging with disability may not be able to take care of their health as well as those without disability are not just due to individual factors and individual choices. Some of the work by Rimmer and colleagues back in 2004 showed that over half of adults with disability do not engage in physical activity due to barriers in their surrounding social and environment. So things like equipment barriers in recreation facilities, negative attitudes by persons without disabilities, or even inaccessible walking paths and sidewalks. These things create challenges for actually maintaining physical activity and health behaviors when you're aging with a disability. Other social determinants of health that can shape the ability to maintain health with aging are things that are playing out across the life course. So these data show the proportion of adults aging with disability who are employed from age 20 up to age 64, again, from the US Panel Study of Income Dynamics. The dark blue line on the bottom are those who are aging with disability, and the lighter blue line on the top who are aging without disability. And you can see that there's a persistent disparity that people aging with disability are repeatedly employed less often than those without disability. And employment has a number of consequences. A lack of employment has consequences for a lack of economic self-sufficiency. It has consequences for isolation, and it prevents also the restriction in building social connections. In addition, a lack of regular and reliable employment over adulthood has consequences for income accumulation, again, over adulthood. And here we see a distribution of the annual household income, inflation adjusted to $1979 to reflect the long-term trajectories of the people that were in this study. And that beginning in the 20s, the dark blue line on the bottom, those aging with disability, are experiencing persistently lower levels of annual household income compared to those aging without disability. And that gap just widens over time. So it becomes clear that the factors that are shaping individuals' ability to maintain their health with aging is something that's not just due to their own choices about engaging in health behaviors. If we think of the upstream social determinants of health, our choices about health behaviors and our choices to be able to maintain health with aging with a disability are related to factors much higher up in the upstream social determinants of health, including our gender, our race, ethnicity, nativity, our social ties, our socioeconomic status, and even the places where we live, our neighborhoods where we undergo and live out our daily lives. So I like this particular framework to understand disability. It's the World Health Organization's International Classification of Functioning Disability and Health. It's based on a biopsychosocial framework to consider disability as really a constellation of factors that are interacting together to shape an individual's ability to participate in society. And so an underlying health condition, such as a spinal cord injury, may lead to limitations in body functions and structures, such as muscle function. This can have consequences for one's ability to dress or to walk or to get across the room, but it can also have consequences for participation in society, for employment, and for social participation. But what's important about this model is that it recognizes that these are not predetermined pathways, that factors in the environment and factors within individuals can modify the consequences of impairments in body functions and structures for activity and participation. And here we're talking about those environmental factors that are natural and human-made environments, specifically factors related to the neighborhood environment. And so this work really is consistent with the sociologist Saad Nagy, who said over 50 years ago that disability is not an inherent characteristic of a person, but in fact is a function of the gap that's between a person's capabilities and the demands created by the physical and social environment. So what do we mean by the physical and social environment? The built and physical environment includes those things like public transportation systems, pedestrian amenities, traffic, also amenities like grocery stores and access to healthcare or recreational centers. It also includes the social and economic environments, such as housing affordability. And it includes things like governance and larger term macro policies about ADA compliance and transition plans, as well as broadband internet availability. The neighborhood environment is important for the health of adults aging with disability. It shapes their ability to access healthcare, participate in society, obtain employment, engage in physical activity, and make healthy food choices to maintain a healthy weight. We argue that broadband internet access may be particularly important for those aging with disability, but there's been very little work looking at the role of broadband for this population. Most studies tend to focus on those characteristics of individuals themselves, such as their own physical limitations or the psychosocial characteristics. neglecting the neighborhood context in which participation takes place. So the purpose of this research that we did was to try to really look at the role of the neighborhood environment and the risk of developing a particular health condition, which was cardiometabolic disease or cardiovascular disease. This work is the work of Dr. Anam Khan, who wasn't able to be here today, so I'm pleased to present this work on her behalf. In addition to Anam Khan, I'd also like to acknowledge Megan Chenoweth, the data manager and curator for the NANDA data, which I'll be speaking about today, and Robert Melendez, who's responsible for the maps that I'm going to show as well. In addition, Iris Gomez and Mao Lee provided additional support for the creation of the neighborhood broadband data, and additional funding came from the National Institutes of Health. So the objective of this work was to examine the relationship between specific features of the neighborhood environment and the risk of cardiovascular disease in a large national cohort of adults aging with physical disability. So we know from the general population, more on an average, that the neighborhood environment is very much an important factor in the development of cardiovascular disease and maintaining cardiovascular health. These data come from a sample of middle-aged adults, and it's showing the relationship between a greater density of resources in the neighborhood, such as favorable food stores, physical activity resources, social cohesion, safety. And as you go from the left to the right of these bars, it's showing that an increase in the availability of these neighborhood amenities is associated with a better cardiovascular health score. So we know this in the general population. The question is it different, or does it stand for people who are aging with disability? So this work used data from a private health insurance payer. One of the greatest challenges in doing work in disability is that we lack population data with disability identifiers. So we're often having to rely on proxies to try to capture populations of people aging with disability. This work relied on a health insurer claims data with over 80 million insured individuals in a plan called the Optum Clinformatics Data Mart. This plan is a service provider across the United States, so it's national. And we identified individuals with a diagnosis of a disability-associated condition before the age of 50. I'll tell you a little bit more about that in the next slides. And then we really followed them up over time longitudinally by looking at their health records and seeing if they developed any cardiovascular health outcomes. And we wanted to understand the neighborhood, so we actually accessed the residential address zip code of all the patients in this database and linked them to indicators of neighborhood characteristics using our neighborhood data archive that I'll explain shortly. However, before I go on, I wanted to just make it very clear that health claims data rely on a diagnosis of a medical condition, which may or may not result in a disability, or even the subjective experience of having a disability. It also is using information that assumes that someone is coming into contact with the health system. And this particular plan, because it's a private health insurance plan, are more likely to be advantaged than those who potentially could be under Medicaid or Medicare. But with those limitations, I just want to then move on and show you what we did. And we identified individuals in this plan using ICD-9 codes, which are billing codes and diagnostic codes for 4 conditions: cerebral palsy, spina bifida, multiple sclerosis, and plegia, or specifically also spinal cord injury in that group as well. So we have 2 conditions that are congenital, cerebral palsy and spina bifida, and 2 that are acquired conditions that somewhat later in the life course, multiple sclerosis and plegia. So there are 26,000 people that we were able to identify in this data set. 58% of them were CP or spina bifida, 19% were multiple sclerosis, and 20% with spinal cord injury. Their average age was 44 years, and they were 60% female. We then followed them again to look at their outcomes over time. So thinking about what are the outcomes of people who have these underlying disability-related conditions? When do they develop cardiovascular disease? So we included people that had been followed in the plan for at least 4 years and hadn't had a previous diagnosis of any of these cardiometabolic conditions. And we identified, again, using ICD-9 codes and ICD-10 codes, any cardiometabolic disease, type 2 diabetes, hypertension, and hyperlipidemia, which are subsumed under that category of any cardiometabolic disease. To get information about the environments that people who are aging with disability are living in, as I said, we used their zip code from the claims data, and we linked it to data on the neighborhood environment from the National Neighborhood Data Archive. I call this NANDA. Something we're really proud of. It's a publicly available data resource hosted through Open ICPSR that has multiple measures of the neighborhood built and social environment at different levels of spatial scale. So different definitions of what a neighborhood is. There's really no definition of a neighborhood. So these are different proxies that can range in area from the census tract to the county, or for data that only has zip code, which is what we're using here, we have to rely on something called the zip code tabulation area. Since zip codes are really just postal routes, they don't capture a space. So these are converted to zip code tabulation areas through a crosswalk that's provided by the United States Census. And then information in that crosswalk is available through our NANDA link. So we wanted to capture features of the built environment that were potentially related to cardiovascular health. So broadband was the number of fixed residential connections per 1,000 households, data coming from the FCC from 2014 to 2020. We captured information on the density of healthcare resources, recreational centers, grocery stores, and other amenities using data from the National Establishment Time Series data. This is a longitudinal database that is aggregated in NANDA to create measures of the count or the proportion or the percentage of these amenities in different neighborhoods. We also have a measure of the density of public parks per 1,000 population and the density of public transit stops per 1,000 population. So we linked these all to the medical claims data that we had based on the zip code of residents over time. But there's also things in the environment that are not so good for health, such as things like the density of liquor, tobacco, and convenience stores, and the density of fast food restaurants, which we also then brought into this analysis. And then we included other measures which weren't necessarily measures of built environment. It's more of the social environment, measures of concentrated socioeconomic disadvantage, as well as its inverse, which is the concentrated social capital or neighborhood affluent. The analysis we did was a Cox proportional hazards model with a series of models that are adjusted for age, sex, and the number of underlying comorbid health conditions that these people have, as well as these underlying social factors in the neighborhood, such as affluence, disadvantage, and population density. And because we have multiple participants that are nested within zip code tabulation areas, we adjust for the clustering of this in our models as well. So I'm going to show you some of our results. The incidence of cardiometabolic disease over the 3 years of follow-up that we had in this population was relatively high. 40% of people developed a diagnosis of any cardiometabolic disease. 10% of this was diabetes, 23% developed hypertension, and 15% developed high cholesterol or hyperlipidemia. This graph shows the relationship between the neighborhood features of the built environment in those neighborhoods where people are living and the incidence of any cardiovascular disease. What this graph shows you are the hazard ratios that are related to living in an area with a higher density of these neighborhood characteristics and the development of cardiovascular disease in the 3-year period of follow-up that we followed them. Anything to the left of the orange line, so hazard ratios that are less than 1, show a protective effect, whereas bars that extend on beyond 1 show a risk. So you can see that broadband internet access, living in a neighborhood with a higher density of broadband connections, is associated with a lower risk of cardiovascular disease in this 3-year period than living in an area with fewer broadband connections. In fact, it's a 12% reduction in risk net of all the other neighborhood characteristics and the individual factors as well. Some of the other things that were beneficial for cardiovascular health were public transit and rec centers, which were all associated with a over 10% relative reduction in risk over the 3-year follow-up period. Neighborhood disadvantage was associated with a 10% increase in risk. So living in an area with a greater density of socioeconomic disadvantage was associated with greater risk than those living in areas with lower density. And interesting, access to health care or proximity to a greater density of healthcare resources was not related to the incidence of cardiovascular disease in this 3-year follow-up period. The results are even more striking for diabetes, even more pronounced, where many of those factors on the left side of the orange bar, so hazard ratios less than 1, actually fall even below 0.7. So for broadband, living in an area with greater broadband connections is associated with 31% relative reduction in risk compared to living in an area with a low density of those connections. Public transit, access to recreational centers and parks is also associated with a reduced risk. Interesting, grocery stores, a greater density of grocery stores is associated with a higher risk of developing diabetes, perhaps because it's access to food that may not necessarily, although it access to healthy food, there could be unhealthy food options as well, which is one of the risk factors for diabetes. So the implications for this, let's think about this. We show that broadband internet access is important for cardiovascular health amongst those who are aging with disability, anywhere from a 12 to 31% reduction in risk when you're living in a high broadband versus low broadband area. There's also an importance for things like recreational establishments and parks to maintain health. So giving people access, making sure they have access to opportunities for physical activity and sharing information is important for maintaining health with aging with disability. Healthcare resources were not independently associated with cardiometabolic disease, and health harming features such as liquor stores and tobacco stores were also not associated. So why does internet access matter for the health of adults aging with disability? Well, there's many reasons, and we don't know really what the reasons are. This would take further work, and it's really our next steps to try to understand the reasons through qualitative interviews or other mechanisms to try to see why does broadband matter. But some of the reasons could be access to telehealth, access to groceries and ordering online, just simply access to information about where to find healthy food, where to exercise, where to be engaged with people, where to find health information, as well as employment and just simply social connections. These things can all play a role in lowering disease risk for those aging with disability. But if we think about the importance of broadband, who has it? Which neighborhoods in the United States have broadband internet access? So as Robin said, despite the assumptions of widespread access, broadband internet is really not equally distributed across America's communities. And there's been a growth of research recently to try to visually understand how this distribution is unequal. And using data from the FCC is a good way to actually visualize some of these disparities. The FCC twice a year requires the internet service providers report on Form 477 services at speeds exceeding 200 kilobytes per second in at least one direction. And they provide these lists at the census blocks, which are small levels of geography, very small levels, and in which they can or do offer service to at least one location. These can be aggregated up and are increasingly being aggregated up to the county level. So this is an example of one of these maps, which shows that there is a lot of heterogeneity in the percentage of households with broadband of any type. The darker color is reflecting greater density, greater percentage of households with access. But also you see that the lighter color means that there are many households that don't have broadband of any type. Again, these are counties across the United States. More recently, Microsoft has also gone into the game and provided some data that can be mapped at the county level. Here we see that these dark blue areas are counties where less than 15% of households have access to the minimum broadband speed of 25 megabits per second. However, county level data is often not enough to understand neighborhood, what people are really experiencing in their neighborhood in terms of broadband access. So if we zoom in a little bit, we can pull on data from NANDA, our Neighborhood Data Archive, to look at broadband internet availability by census tract. I'm looking at Michigan here, and you can see that the county level data completely miss a lot of the differences and the inequality in access to high-speed broadband internet in these different census tract neighborhoods. Now, these are only at 10 megabits per second, which is well below even the minimum required standard, but you can see that there's quite a bit of heterogeneity in what people have access to across Michigan. If we zoom in deeper here, even to the county of Wayne, you can see that there's a lot of disparity in access to broadband internet in the city of Detroit, where there are very few census tracts with that are red that reflect a greater number of residential fixed connections at this speed. So I'm going to just leave that with you, and we're going to move on to talking about the policy implications. But I just want to remind everyone again to think about that fact that disability is the expression of a physical or a mental limitation in a social context. And I'll close with this quote by Hugh Herr, that a person can never be broken. Our built environment, our technologies are broken. We, the people, need not accept our limitations, but can transcend disability through technological innovation. And broadband is one of those potential technological innovations. So I'm going to pass it off now to Robin, who will be discussing the policy implications.
Thank you, Philippa. I'm just going to highlight that there are many policy impacts related to broadband internet access for individuals with disabilities in particular. I'm going to focus primarily on access to telehealth services and touch briefly on employment and caregiver support. First, for telehealth, I want to identify the definition of telehealth, and there are various definitions. For this review, I'm focusing primarily on telehealth as a two-way communication that does include telephonic communication that enables the provision of clinical healthcare services with a strong preference for audio-video communication due to the better outcomes associated with that. During the COVID pandemic, telehealth has become an essential form of health service delivery. It's important to note that before COVID, adults with disabilities had a much higher need for physician visits, as noted here, yet they had a much lower access to technology compared to people without disabilities. This has impacted their ability to receive services these last couple years, and some of the findings subsequently reflect on this. I also wanted to highlight some issues related to affordability and racial disparity. As noted earlier, affordability is a key factor in internet access. For people with disabilities, the percent living at or below the poverty line is more than twice that of people without disabilities, almost 26% in 2019. And for African Americans with disability, this is even more of a significant barrier, with 40% living below the poverty line. The pandemic has provided an opportunity to examine both the benefits and challenges of telehealth for the broader population as well as individuals with disabilities. The benefits, as I've highlighted here, include the reducing the need for transportation, which has been a long-standing issue and a major factor in social determinants of health for this population. Access to telehealth obviates the need for transportation for many services. Increasing the access to specialists, especially behavioral health specialists, has been significant, with 30% or more of services provided by behavioral health providers being provided through telehealth over the past couple years. This also supports independence and empowers self-management in many situations. which is another benefit. Challenges. There are numerous challenges related to telehealth, in addition to the challenges of access to broadband internet. For individuals with disabilities that affect communication, video may be inaccessible for those individuals. For many people, they need assistance from a caregiver to utilize telehealth services. So the availability and knowledge of a caregiver is essential in those situations. And we need to keep in mind that not all care can be provided by telehealth. In particular, there is still a strong need for in-person services and care to allow many individuals to stay in their homes and receive the proper supports, or for services that require direct provider contact. And then finally, there are privacy considerations in settings where telehealth is used. And that's something that is also noteworthy and needs to be considered as well. This slide represents the analyses that were done by CHART, the Center for Health and Research Transformation, where I work. And CHART analyzed data from a survey of licensed Michigan physicians conducted in April and May of 2021. There were about 2,200 physicians that responded, 2,188 to be exact. And they highlighted the technological challenges for patients as the top challenge reported by physicians, and reimbursement factors, which vary considerably state to state and payer to payer, as the most commonly reported barriers for continued use of telehealth. And before I move off this slide, I want to share a quote with you from one of the physicians that responded. "I'm in a rural area. Many patients lack a PC or smartphone. They have low-tech flip phones, and in many cases are elderly and not tech savvy. I use audio or FaceTime only, and many don't have or understand FaceTime." This is a barrier as reflected by the providers. During the first year of COVID, there was wide variation in the rate of telehealth across states. This reflects the Medicare population, with the highest use being in the Northeast and the lowest being the South and the Central North states. These differences are largely due to differences in state regulations for telehealth, provider acceptance, and also internet access, as we've been discussing. Looking at the same data within the Medicare population, younger beneficiaries with disabilities, often dual Medicaid, Medicare beneficiaries, had higher rates of visits, which is good. However, keep in mind that this group also has a higher need for services pre-COVID. Prior to March 2020, when the public health emergency was put in place, Medicare and other payers paid for telehealth under only very limited circumstances. It was often restricted to rural and professional shortage areas and established patients and very limited types of providers. With the public health emergency, to allow for continued provision of health care in a safe manner, the federal government removed many restrictions for the Medicare program. This included location, delivery modalities, such as audio only and remote monitoring, expanding the number and types of eligible providers, expanding the reimbursable services and paying for these services more than had been paid in the past, adding non-medical services such as home and community-based service assessments, wheelchair education, and so on, allowing providers to cross state boundaries, and reducing or waiving cost sharing. The COVID pandemic has created an urgent need for telehealth, and it is very likely that telehealth will be here to stay. I do want you to keep in mind that programs such as Medicaid and commercial insurance are defined and monitored at the state level for the policy and reimbursement arrangements, and that Medicare policy is governed at the federal level. So the steps that are being taken are occurring at both state and federal level to maintain changes that have been put in place with the public health emergency. I also want to talk briefly about employment and then caregiver policy items. With employment, the pandemic has impacted the employment of people with disabilities more severely than those without disabilities. And you can see the statistics here. A loss of employment by 20% versus 14% for those without disabilities. And past trends indicate that the rate of job recovery will also be slower. Access and affordability for internet services is a major factor in job recovery and the ability to work remotely. For caregivers, there is much evidence that caregivers benefit greatly from broadband internet access. There's been a lot of study of the educational benefits, but also interaction with other caregivers. A study back in 2015 reported significant outcomes showing improvements with digital health technologies and caregivers related to their ability to support the individuals that they were caring for. And this is another area that gets neglected, but certainly needs attention from a policy perspective. In closing, I wanted to stress that in advancing health equity and other benefits of technological innovation, we need to assure that we don't leave those living with disabilities behind, and that we include their voices in the decision-making process. While the influx of dollars from the Infrastructure Act will jumpstart continued policy and support, will jumpstart near-term access to broadband internet for underserved communities, continued policymaker support and oversight will be needed. And as noted, the pandemic has helped confirm the need for permanent changes in telehealth regulations at both the federal and the state level. Together, these opportunities can help many people, especially individuals with disabilities and their families and caregivers, improve health, secure employment and education, and benefit from services and connections across all geographic areas and communities. Philip and I have provided various references that you can access when you receive these slides, and our contact information as well. We'd be happy for you to contact us. I want to draw your attention to our next webinar, which will be Thursday, April 14th from 2 to 3 p.m. on reimagining primary health care for individuals with disabilities, presented by Dr. Michael McKee. And then finally, I also wanted to acknowledge that the content of this webinar has been developed with a grant from the National Institute on Disability in Independent Rehabilitation Research, NIDLR, within the Administration Community Living, ACL. And that the content of this webinar do not necessarily represent the policy of these organizations. And I'm going to pass this to Dr. Vino to respond to your questions.
Thanks very much. So for your questions, I want to just ask you to please type in your questions using the Q&A box on the bottom of your Zoom window. If you must use your audio, please click the hand icon at the bottom of your Zoom window to raise your hand, which lets us know that you'd like to speak. Someone will unmute you to ask your question if that's the case, and a prompt might appear to ask you to unmute yourself. This action will temporarily turn on your microphone so you can ask your question. Okay, so I will start off with a question from me. This is a question for Philippa. So some of the built environment issues that you talked about, like recreation center density and grocery store density, and definitely broadband internet access, tends to be concentrated in rural, in urban or suburban areas, outside of high poverty areas. Do you have any thoughts about an interaction between your analyses and rurality? For example, do these neighborhood characteristics help to explain rural health disparities in cardiovascular health, or perhaps in cardiovascular mortality, in your opinion?
Thanks, Tiffany. Yeah, that's a good question. And it's something that comes up often in this kind of work. And just to clarify, we did adjust for population density in our models to try exactly to get around, to try and address that. But it is true that there is, potentially a different piece about rural versus urban. I do think that it's important to think about trying to find specific data that would better capture the challenges in rural areas, because I think the Optum data really is clustered in urban areas. So I don't know if we had the ability to kind of look at the differences by rural urban status, but I think it's a really important area for further research.
Thank you. Very interesting work. So the first question from the audience is, to what extent do you think the relationship between broadband and health of disabled people found in this work represents an ecologic effect?
Thanks, Kara. So great to have you on the broadband webinar. So good to hear you here. Yeah, this is a question that we also get as well, which is, this, just to make sure that I'm understanding you correctly, you're asking, are these really just associations but not causal? Could it be that people aging with disability who have cardiovascular health problems are more likely to live in areas without broadband internet access, versus is it that broadband is actually playing an important role in preventing cardiovascular health problems? I think this is the limitation of any kind of neighborhood research. We don't know really if there's a true causal effect, but I do think this analysis tries to be a little bit more rigorous in that it's looking kind of prospectively at access to these resources and then subsequent incident conditions. But it's a really good methodological question that services a lot. And I think we need to do more to try and look at more of the causal relationship. And I think qualitative research is one of those avenues that we could really find out by asking people aging with disability, what is the role of broadband for you? How challenging is it? And what impact does it have on your health?
Okay. And then another question from a different person. Why do you think access/concentration to grocery stores lowered cardiovascular health? What could this be capturing?
Yeah, this was interesting for us as well. And I think there was another question by Stephanie who also noted that it just could be that an area with a higher density of grocery stores is also just a more dense urban development area, and that could actually come with additional features that add to the risk of cardiovascular health. So it could be more access to, polluting sites, or more traffic, or things that could also be causing a risk, or they're just simply because you're in a more densely populated area. So again, these are things that are important to think about, and then kind of teasing out like what are the individual effects and different roles of these different features. We tried to do that as best we could by looking at multiple different features, but yeah, further research to really dig into that and find out more.
One thing I was thinking about around that also is that many of the larger grocery stores are located quite near highways at this point. And so definitely when you're talking about traffic and air pollution, certainly there's a documented relationship between air pollution and cardiovascular disease. Another person has asked, what is the implication of healthcare in an area being neutral to negative on a neighborhood?
So we found, that proximity to healthcare, having more healthcare resources was not associated. And there are two things I can say about that. I think this is looking at prevention of a cardiovascular event, which is not so much accessing healthcare that's important for that. It's really preventing things like the risk factors for a cardiovascular event, which are more likely to be located in the neighborhood context. So being able to access healthy food, being able to engage in physical activity, those things are preventive. And so it's sort of getting at what are the resources in the neighborhood that actually are important for preventing disease, so before you even have to access healthcare. So these are really sort of upstream preventive measures, I think.
Okay, somebody who hasn't asked a question yet has asked, access to broadband in rural areas is one step. Is there any discussion to access to technology so people with disabilities in rural areas likely to have economic barriers can access the internet? It's tough to get on the internet superhighway without a vehicle. Perhaps this is premature since we want to focus on getting broadband out first. So this might be a question for Robin.
Yes, I can jump in here. And this is very relevant because, the Infrastructure Act is going to support a contribution to the cost of internet service once it's available for people in rural areas or other areas without the infrastructure. However, there is still all the other aspects of access, which include access to a computer, a smartphone, and so on. So it's not as simple as just supplying, as you indicate, the superhighway without the vehicle. I think that is why there's going to need to be continued review and support from policymakers to truly make this equitable and accessible to all people, like our phone service is and has been for years and years, particularly back in the days of the landline. The broadband internet has been thought of in a similar fashion, where it's something that should be available to everybody and not just those who can afford it.
Another question, in terms of caregivers, are you also considering the unique considerations for internet access and people living with a disability who are part of the sandwich generation, i.e. they may also be caregivers for their parents and children, as well as having a caregiver, and somehow I lost it on my, okay, as well as having a caregiver. And this may tie into your statistics on people living with a disability, 60% female. And I also think there was a drop in income when people are in their 40s. So sandwich generation.
I can respond to this.
Sure.
Yeah, I can respond to this and answer yes. When you're talking about caregivers, we're talking about informal caregivers largely, who are often family members, but in many cases may be friends or other support people who are available to the individual in need of caregiving. So the sandwich generation is a major factor because of all the stressors involved. And what we found through some other research that we've done that looks at caregiver stress is that this is one of the major factors for stress and ability to provide appropriate services to the individual in need, and that it's amplified when those individuals are also low income and don't have access to services to provide education and support and connections with other people to allow them to maintain lower levels of stress and provide the care that's needed. So it compounds upon itself. And it's a major consideration because as we look ahead into the future, I know this webinar is not on caregiving, but there are going to be many fewer caregivers for the volume of people in need of care, including this population that we're looking at, individuals with disabilities.
Okay, so it's 3 o'clock now. So we will be wrapping up shortly, but wanted to end with stressing how important this question is with respect to neighborhood environment and aging with a disability when we look at these kinds of health outcomes. And when we think about, as we have a massive influx of money coming through the Internet Infrastructure and Jobs Act, it's going to be quite important to think about how we are going to thoughtfully allocate those funds and how we can ensure that as there are investments that we are helping to lift all boats and that we are increasing access for people with disabilities as well as those without disabilities in the population. So I will let the people whose questions are outstanding know that we will be, the speakers will be following up afterwards with answers to your questions. But thank you so much for attending today. It's been a really informative and important presentation and discussion. Thank you.